from the other side. Great. I can see Dr. Sharma and Dr. Khera. In structural heart life case number 1, an 82-year-old female. Go ahead from the cardiac cath lab.
Okay, we thank all our faculty and of course great faculty and all the audience. I was very happy to see better show up today compared to our last year, every year growing, and maybe it's a Sinai. Maybe we'll keep it a symposium at Sinai in the future. But having said that, and great lectures, I mean, what educational feat everybody has had in last 1 hour and so. All the faculty, it's the only one we need to introduce our fellows, Supawat. We have 3 structural fellows with our program of about 500 plus tower and 100 plus clip and other procedures like 700 structural cases. So this case, very interesting, and that is what a lot of discussion happened with Kendra and Vinny, and we are going to talk about this patient. Let me just go back. Okay, this patient, which exactly is I would say the trouble. Trouble is like DES coming back. So we thought the DES has cured everything, but no, DES restenosis. Same thing. We thought tower is the final answer when we are doing it. Patient probably won't live more than 10 years. And now we actually have seen some failure even before. And of course, those who outlive the tower valve life. Now this patient is an 82-year-old, has symptoms of heart failure and heart block, and has a transfemoral tower using 23 millimeter S3 -1 in March of 2019. So about like the 40 months ago, 3.5 years. Coronaries are okay and start having more shortness of breath and had a echo done, which showed severe prosthetic stenosis with the mean gradient of 36 and valve area of 0.67 and velocity of about 4 with minimal PVL. Clearly a degeneration of the valve with a good ejection fraction. And this is the echo, which have been recorded, but now we'll go to the live echo with the stem Lerakis on that side.
Yes, good morning again. So this is the mid-esophageal views showing the RV function and appears normal RV function, actually 3D, ejection fraction 68%. Since we have the 3D, this is the mitral valve 3D, surgeon's view, minimal mitral regurgitation.
Yeah.
This is the 3D of tricuspid, minimal tricuspid regurgitation, and moving to the aortic valve. As you can appreciate, the leaflets are very thickened, calcified with decreased excretion, and also there is mild to moderate aortic regurgitation. The short axis view, again, the Sharma's fusion of the right and left cusps of the prosthesis with a mild to moderate AI. And as you can see, the peak velocity we got here is 3.26, as you say, that after the procedure, the next day, the velocity was 1.2, maximum gradient 42, mean gradient 21, valve area of 0.7, 0.8, and the index 0.5 with throw volume index of 37 ml. Pressure half time of the AI 446, so mild to moderate. And we did a 3D measurement of the stent of the prosthesis at LVOT, which comes about the same as the CT, 3.6 centimeter square area, 6.7 perimeter. And also we measured the height of the left main, we got 1.3 centimeters. And also, I know it's important for the left main in this case, also today we can do flow, and this is the flow of the left main by echo. Thank you very much.
Great, and we'll get some opinion from the experts on the panel. And because this is a little unusual case for us also, and patient does not have renal failure, creatinine is good, and we know there's not a halt. Clearly, it's a degeneration of the leaflet. Well, we'll ask the opinion, but let me just go through quickly. Echo has been done, and this is what the time we wanted to show you, and then we'll come back and ask the question. This is the case back in March of 2019. As you can see here, height of the left, the right, because of the just 10, we did a protection with a coronary wire at that time, and these are the valve, and this is where we had it. Clearly, the top of the S3 frame is against the top of the left main, just at that level, and the patient did very well. It looks quite good. We didn't feel, echo-wise was good also. We didn't feel that there is under expanded valve, although it was 23 minus 1 cc at that time. And just in 3.5 years, which is unusual for this type of patient, which does not have any renal failure, has come back. So now, of course, Gilbert has reviewed this case very in intricate detail. Maybe we can ask the faculty to give the opinion, the Vinny, Kendra, and others, that what do you think went wrong when we deployed this patient, this valve 3.5 years ago?
Yeah, perhaps show us back the aortogram while the panel is talking,
Okay.
so that they can refer to it. Yeah, go ahead, Vinny and Alex.
Question, George, regarding the mechanism of failure. Because is echo enough to understand? Because generally, less than 4 years, we think about heart and leaflet thrombosis. And according to Dr. Sharma, this was really the mechanism is different. So we generally ask these patients to undergo CT scan to make sure that you understand what is going on. Is echo enough, Stan? Are you comfortable and
Yes.
you are sure?
Yes, Alex. Good to see you this morning. Yes, there is no heart. You know, heart looks very different. This is, as you can see, calcified leaflets with a commissural fusion of the left and the right cusp. So, I mean, heart looks completely different. And I know the gold standard is CT, but...
No, but we did the CT. No, just to say that, yes, we did the CT on this patient, thinking that may be causing this gradient, and CT was clearly, was not, no halt. So
No, we review.
Stem just said on the echo was nothing in terms of the halt and not the CT.
Clearly premature.
No heart.
Clearly premature degeneration. We're going to come to the halt when you show us the CT, but let Dr. Bapat have a comment.
Yeah.
He wanted regarding this aortogram of the first case, just the final result of 2019. Might be any clue now in retrospect, or maybe not?
So I think, again, this highlights a point I made, Dr. Sharma, just in the talk, that in such situations where coronaries are at risk, it's a smaller valve. We know that patient may need, a redo procedure. Should we start thinking of implanting it slightly lower? And we do that in our center now for patients, especially on dialysis, where we know they're going to come back sooner. So we have started identifying patients where we have proactively started implanting in lower, so as to keep that window of second TAV-IN-TAV open. But otherwise, I think beautiful result. I think the valves expanded nearly fully, but the CT dimensions will educate us a bit more.
Yeah, Dr. Grubb?
Okay.
Not to criticize the organizers of the conference. There are a couple of things that I worry about in this particular case, and the point of my presentation was make the first valve the right choice and then implant it perfectly. And here I understand why you landed deep to preserve access to the left main, but then selecting a 23 millimeter and leaving a CC out, I question a few things. One, do you have an underexpanded valve that has some pinwheeling of the leaflets from the time you started, so that the valve is not functioning well immediately? Next, is there some patient prosthesis mismatch? Was this too small a valve for the patient, and could we have done better with a different valve? So ultimately, now we have 3 commercially available valves for these older patients, and would it be a better first choice to either use a superannular self-expanding valve or a self-expanding intraannular valve? Would you have gotten a different result? And I would suggest that those things could now be explored. And there's even new technology doing AI simulation that could help us answer those questions. I mean, I think at the time, 2019, we were doing the same thing.
Right. Well,
And just to update on that, this is an unusual case. I mean, we have seen some cases of degeneration, and I'll ask Anu to comment on that. Particularly, those were the cases which, I'm not talking about halt. Halt has been ruled out, but valve degeneration, the renal failure patient. But this was really, very unusual case, and based on the data, that whether with the small annuli, this will spill into that a small annuli or a smart trial type of case, and with a Swiss registry, hemodynamics is a little better, but long-term reintervention was equal in both self-expanding and balloon expandable group.
Yeah.
Have you seen?
Can I?
Dr. Kapadia has a comment. Go ahead.
Renal failure patient.
Yeah, I have one comment, Dr. Sharma. Samir, so one thing we have seen is that when the sinuses are small, so see this patient has a very small sinus. And this kind of patients, so we are ready to write our paper too of saying that what is the sinus washout time. These patients, I like to give them anticoagulation after the TAVR, because I think your valve implantation is perfect, and I think 23 minus 1 is what I would have done. But I think that this kind of valve anatomy, if you see, because the pannus grows from the sinuses also. So you many times, I don't know what you found on the CT scan, but many times the growth is from the commissures of the valve growing inside. And this is because it's touching the walls of the aorta.
Yeah, let's look at the CT though. If you have any further discussion,
Okay.
please advance towards the
Let's
CT.
keep going. Yeah, sorry. This is the TAVR app. So index TAV and measurement, we have already shown it. Right? This is the index time, correct?
So you can see here that the valve is underexpanded, right? So you can see the mean diameter on the outflow and inflow is around 350. But the waist, you can see that this is a work courtesy of Miho and Minneapolis Harbor Vini. That is just 20. So it is underexpanded despite 23 minus 1. Next slide.
My question is, anyone want to comment? Are you doing a 2 inflations? Like in the coronary we do a stent, very commonly 2 inflation. Are you routinely doing 2 inflations in these cases? When using a small valve particularly?
Hassan.
The risk of annular damage is pretty high. So unless it's really underexpanded, we don't.
Don't do it. Okay.
We do sometimes do a 2-tap approach, especially if we have concern on root injury. So sometimes we underfill by 1 cc or 2 cc as you did in this case, and then sometimes do a post-dilatation if on TE it looks good. But I appreciated very much Kendra's comment on simulation, and in line with what Samir said, we're working with DASI simulation to try and predict these early degeneration. And the small sinuses significantly affects a parameter called the normalized circulation. So this is one of the important factors, as well as having a waist. So it's very multifactorial. It's very hard to understand. I'm interested whether also the commissures were aligned in this case, because that is also a factor.
All good points.
Even for the balloon expandable, that is correct. So this is now redo TAVR app. Now identify coronary risk plane, so which is
so you can see that here, actually we got the, and Vini worked up this case with us, and you can see that the left coronary, and you can see that on fluoro later on, just sits right at the, what we call the wrist plane. So pretty much the top. So that makes it potentially more favorable, and next slide. You can see that here, just to educate the audience. Remember, the top of the frame is not where the leaflets are. Actually, it's where the commissure taps are. And you can see the blue line being the neoskirt plane where it will become a tube graft versus the coronary at the bottom of the left main is pretty close. It's pretty much level. So this does give us a little bit more comfort, but obviously this is not the same as coronary access. Next slide. So you can see that this is our own analysis, pretty consistent. Next slide. And then the app then tells you basically what is the second valve. So here's the big question, right? You can see the valve is already underexpanded. So next slide. And so we looked at the potential number 1 in implant position, as Vini has outlined in his talk. And then the next, if you move forward, you can see that here, because we're essentially the same. Next slide. And then so you have low risk acute coronary obstruction. Next slide. And then so what you're looking at then is how do you size the second valve? So this is where Intuitive does. You basically average the 3 measurements that we did, and you can see it's around the range of a 20 SAPIEN actually now. Of course, you want to look at the BSA as well to look at PPM, and we calculate that for this patient. And you can see if you put a 23 in there, assuming it expands fully, which probably won't be the case, we will not have PPM. But even with a 20 S3, you only have moderate PPM here. So the discussion question with us was that should we do 20 plus 1? Or 23 minus 1. And the consensus, at least when we discuss based on the sizing, is to go 20 plus 1. What do you guys think on the panel? The EVOLUT is another interesting choice, but you can see the root is rather small. So we were concerned about this patient is only 82. It's not 92 in terms of coronary access afterwards would be challenging with that such a small room in terms of STJ to the top of the S3 frame.
So let's take the vote.
Yes.
People will say 20 plus 1 or 23 minus 1. Knowing 23 minus
Yeah,
1 was done.
Dr. Herrmann has a quick comment. Dr. Herrmann?
So there's no data, obviously, to answer this question, but I do think if you put another 23 in this small valve, it'll be even more deformed. And although maybe you'll get a slightly bigger valve area, at least predicted-wise, it's going to be deformed, and probably in this patient, there must be patient factors that led to the early structural valve deterioration, and they might be even worsened the second time. So I'd probably go with a 20. Moderate ppm in most studies has not been shown to be a predictor of bad outcome, and particularly in an 85-year-old. So I'd probably go with a 20. My only other comment is the left coronary is predicted to be safe here, but it still looks very, very close. And I would have a very low threshold for coronary protection at the very least here.
Yeah. Beautiful. Good. So both we are kind of, you didn't say it, but we heard it because both your opinions all have been done. We clearly coronary risk assessment, which we had done. We, the wiring at least, not necessarily the stent, we thought. So this is where we are now. Alignment here, the alignment of the...
Yeah, so, as you know, balloon expandable valve, at least in current generation, can't be aligned with the SAPIEN 3 and even ultra resilient platform. So you can see this very moderate commissure misalignment. You can see where the commissures are. But thankfully, this case, and you see it on fluoral, the trough of the outflow sits actually at the left main. So you see that we're able to pass the guide through from the top versus through the frame, because that's really the big question here, right? How would you protect?
We showed both.
Right, exactly. And Sahil and Dr. Kini will show you what the visualization of both.
Okay.
Maybe we just fast forward.
And the iliac is good, so the rest is all. Let me just complete and go through it.
Yeah.
So this was the redo positioning, left with the left main protection. That's our plan. And we changed the approach, as you said, 20 millimeter plus 1 cc with the wire protection. So tell us now, both of you, where we are. Go to the fluoro, please. Yeah. Okay. Feature sentinel has been done. Yeah.
Yeah, that's
Okay,
a picture with a guide. Yeah, show us this picture with a guide. Yeah, very easy access. Yeah, very easy
Safe
access.
looking, to me, I think the left main will be fine. And again, the decision between 20 and 23 is a tough one, because I don't know that what I would do personally. I like the idea of 23, but I know that everybody feels that 20 is a better idea.
I didn't hear any comment regarding EVOLUT here. Anyone might use EVOLUT. Dr. Grube?
That is an option, but I think it is...
Dr. Grube, not too enthusiastic about EVOLUT either. Okay, we move on for this case.
Okay,
Yeah.
good.
Okay,
Good.
go back.
Yeah.
The question now, protection-wise, are we going to leave the guide above or through the cell? I think you should leave it above,
Above.
not through the cell.
Yeah. Okay.
So we're ready.
Good. We're ready?
Yeah.
We cross the valve. We can show that. I think we just used our usual technique to cross. Earlier also you did.
What was the gradient when you crossed?
We can we show
Show the hemodynamics on one side,
by the side?
It's about same 35 that we got other way.
Yeah.
I know this is in the anesthesia situation, so probably 10. I always say give the 10 for that.
Maybe you could also discuss what your coronary protection technique
Yeah,
is. Do you leave a guide in? Do you put a wire down? Do you put a
Is
stent?
the wire and guide floating above. That's why they decided.
Yeah.
So the concern with
So
that is-
usually, like last time also, we felt that the guide catheter and use the guide catheter as to inject the aorta, for your injection. So you don't need to put an extra pigtail. Use that, taking it out, and leave the wire. So last time also we just did the wire protection. We knew about, but we did not do the stent. So many cases we will do, and one of the case which will be shown later today, we had to protect both of them. And after the deployment of the valve, we did a double RCA and left main chimney stent. But in this case, that time we thought the wire, and Sahil was very confident, probably, took the edge. I mentioned that opinions of our faculty there the same way, that just the wire protection will be good enough, and that is what we are there now.
Now, have we discussed if we have to pre-dilate this previous?
So let's ask the panel. So because the valve is underexpanded, we feel that we should pre-dilate this just to make it easier for the second valve to cross. I know some people don't do that or not in favor of it, at least in my personal humble opinion, that we feel that it gives a little better landing zone. Obviously, we'll wire the left main afterwards. This is just to optimize what I call, because we've seen that in Jannar has done some work on it, that you cannot really post-dilate and expand the frame afterwards, with two frames in place.
Okay, 180.
Base 180.
It would be interesting to inject contrast when you inflate the balloon to see what happens with the coronaries.
Well, there is a waste, clearly, yeah.
Okay, stop it.
And,
What size balloon was this?
20 size balloon, I assume.
This is 21 true. 21 true.
Yeah, see now actually, that little dumbbell type waste last time, the question was, and that's what I asked the question earlier, should we have done the second inflation back then without taking the -1 cc out, and maybe that waste would have disappeared and the healing of the valve would have been a little different and not reached in 3.5 years.
No, that's a very good point, Dr. Sharma. I mean, we would now actually intentionally undersize and optimize the frame expansion of some of these valves, right? In borderline anatomy, obviously, for concern of rupture. And we published papers showing that there was no gradient difference, even when we but you get the pro-CT, they're more normally expanded.
So this is a very good sign. You see the catheter just went through the STJ into the coronary. So
We'll say that, please, Rose. Yep.
So
What is the role of just balloon? This is the question.
Yeah.
So why don't we stop?
It's a pretty
Go,
calcified.
If
No,
it
but
is-
I would
don't know
say
how
that,
calcified,
Samir,
that's
if
why.
it was only under expansion, then yes, which we have done few cases. But since there is a clear-cut valve degeneration both on the CT as well as on echo, that's why we thought we put a valve in.
So we actually showed a case on that with an EVOLUT that was degenerate. We were worried about coronary obstruction, right coronary. We actually did a live case, and we ballooned it before, actually 6 months ago, as a palliation. Patient Jehovah's Witness, inoperable, and then but he felt better. But then 3 months later, the gradient came back, and we have no choice but to actually put a second valve in.
Let me a new.
In that case, we relate to one of the valve meeting, Hyderabad valve last year, because balloon alone didn't work.
Give me wet.
Dr. Sharma, the other important thing is the slight difference is here if the guide goes easily, we just put the wire. But if there is difficulty in placing the guide, we also put the stent. Because it's extremely hard to pass the stent later.
Yeah, absolutely. No, fully. There was, if any question was that we'll have a trouble, we were actually prepared. So actually, when I send, initially we were thinking that we put a preempt stent, but then by looking at it in multiple views, and today when they did the picture, we clearly, everybody reviewed it, and it felt that there's no need to put a stent. I think the wire alone will be okay.
Yeah, indeed, the way the previous angiogram, etc., looked, there was more concern for a left main proximity than it actually is in reality. So that was a favorable revision of the plan and simplification after the original angio before. And someone, obviously, just for the audience purposes, someone is actively pulling the guide or holding the guide so it doesn't dive even more in during the advancement of the valve, because one catheter can push the other a little bit.
So is this a 20 or 23? What did you choose in the end? 20?
This is 20 plus 1.
20 plus 1.
Plural.
Yes.
So artificial 21. Man-made, although it's not actually 21, it will be 20.8.
Artificial,
The other issue you have to worry about with a 20 is that it is a shorter frame. So you have to worry about leaflet overhang, and you're positioning a little more carefully than with another 23 and 23.
So I think
because it's going to fully foreshorten from both ends.
Is you do outflow to outflow here, then you will be fine. In fact, you can go down up to commissure tab, and then you can align it there. So
So
this will
everybody,
work quite well.
We don't need to inject.
how do you like the current position where they are?
Okay, good.
Not more.
How
Okay,
are
180.
Let's test. Let's test.
everybody sort of likes it here?
No.
Everybody likes it here. I'll make sure the guide is quite out of the left main.
Okay, good.
Okay, off.
So as you see that we always test before we inflate.
Okay, ready?
Just to know that where things will be.
Long pacing run.
We are ready now.
180.
Very slow.
Going up.
Very slow.
Yeah. Kind of went up a little bit, but let's see.
No,
It's okay, don't worry, don't worry.
Very good.
Okay,
Excellent.
I'm full.
Yeah.
8.5.
Yeah. Yeah, very nicely. It's very low blood pressure during the pacing. That
Let's post
hopefully
that.
goes for a very good result.
Let's take a picture first.
Yeah.
Let's take a coordinate picture, please.
Yeah. Okay, so hemodynamically good, ECG is all right.
No, PE up pace.
Tee up, please. Tee up.
Yeah.
They're taking a left main flow picture also from T.
Yeah, now you can do it. Now put the TV.
Well, should we post dilate now? There's
Yeah.
no. I mean, we just post dilate.
Yeah. Go back.
All
So
right.
again, this is our Mount Sinai technique that we like to pre and post to optimize the second valve frame expansion as well. So
Particularly when one of the big mechanisms was that little waste of the in the middle. Yeah. Let's go.
Okay. I want to check something.
So Vinny looks pretty good there, huh?
Looks
From
very good.
placement standpoint.
The initial impression, everyone here, is very positive. Very perfect implant height-wise, and let's see how the post deal. You're going to plan to do a post deal with 23 through. Is that your idea?
no, we'll use the same one.
Same one.
And do you want to add one more CC inside, or that's okay?
That's fine. We can add
Why
one.
don't you add one more CC? So now again, man-made.
Man-made 21.
T is okay?
Yeah.
21.5.
The left main.
So I think the question I would
The level of
ask
the left main
Dr.
is
Sharma is,
I'm sorry, what?
Do you want to add one more or you're okay?
if you are adding one
At the level of the
CC,
left main.
We can change. Look at the flow. We can look at another flow. Yep, afterwards.
No, I'm not saying to do anything. Going higher up.
Give one CC.
So, Gilbert, why don't we use the 21 true balloon instead? Because it usually gives better expansion. So, instead of using 1 cc extra in
What's
the
the guy?
top-line balloon.
Yeah, that Dr. Bapat brings out the true balloon possibility for a more optimization.
Me little flex.
I am advanced.
Okay.
I guess
So
another
one
time.
thing is you center the wire when you cross, right? Because otherwise you get stuck in the outer curve. That's a trick that we've seen as well with TAV-IN-TAV, that you rub against the metal frame. So
Now, where is the force of the balloon? The maximum force, the middle of the balloon, needs to be exactly where the least
Okay, 180.
expanded area is.
Hopeful. Now probably will be like 21.5 millimeter. We have added 2 cc's now.
Yeah.
Okay, good.
Good.
8.5.
yeah, you see it. It actually.
And went to 8.5 atmosphere. Get it ready.
Off.
Yeah.
Unflexed.
Yes, I did.
Okay, we'll do some hemos, okay? Keep a pigtail, please.
Right.
Sahil, I'm walking it up, okay?
Get me a picture.
Okay, go ahead, Stam. You got wire?
Hold on, let me do a coronary picture.
One second, take this one up, corner picture, so that we take that thing out. Good.
Even better now.
So far good. Okay.
Corner picture even better. Excellent.
Yeah.
You put some color, please.
Okay, we are doing a pigtail now.
Oh.
Oops. Pick it up, please. Take the color off. All right.
And actually looking quite good. So we're probably a 1 millimeter below the top frame is slightly, maybe just a 1 or 2 millimeter below.
Put some color there.
Definitely not above.
Yeah.
That's the key.
But it's interesting that the 20 inside 23, when we fully expanded here, is actually the same height.
Yeah.
You see that here, right? Inside.
Because it doesn't have
It has to,
anything
yeah,
outside.
exactly. It doesn't expand more. So this is something important for the implanters to know, that it might not be actually shorter than actually the first valve. You can see that this does not fluoroscopically look shorter at all. In fact, it's the same. And we'll do a post CT on this patient afterwards as well. So
It suggests.
Stan, how does it look?
Yes, looks great. Looks great to you.
Fully
Okay,
dilated.
show the echo.
Lights, please.
Yeah. Wow.
Short axis, also you can see good flow in the left main by coronary flow by echo. Okay, take that first. Yeah. Okay, take that, long axis. Long axis.
Yeah, it's a Resilia. It's 120 Resilia.
Great opening. Let's put some one.
The other thing I don't know if you noticed, actually, the valve had to rise up a little bit as well when the inflation.
Go to stomach.
So it's important for the first operator to control the position at the end. It's a slow inflation that you saw there. Because otherwise the valve may end up running a little bit higher than you want.
Good. Beautiful hemodynamics. That's good. Yeah.
Can we share the hemodynamics, please?
It's good. Perfect.
No PVL.
Yeah. You show the hemodynamics, guys. Normal, no gradient.
Yeah, that's gradient there.
Absolutely no gradient. And it looks good. We are ready for the second case.
Yeah, this is
So that's Stanley, you do
Very
gradient for
good.
us as well on the PE.
You see,
Did we, yeah.
the second.
Will you give anticoagulation to this patient?
Anticoagulation decision for this patient is probably pending, but will be closely considered.
I think we should give it, you know.
So no. Yeah. Well, the only problem is, that she had 3 falls and she had 1 intracranial hemorrhage about 9 months ago.
All problems here, all problems in one case.
Yeah.
All problems in one case. So valve-wise would be a benefit. Patient-wise, I don't know about that. So we'll rethink about it.
This is a patient where you will do a follow-up CT at 1 month, because this is very important.
Yeah, very good, very good. Definitely CTA at 1 month in this complex repeat valve cases is quite well taken recommendation. Yeah,
And
definitely.
again, another point Dr. Herrmann mentioned is there is no data. Actually, we presented the data at the HVC meeting, which is going to be published soon, is when we use in vitro sizing with bigger valves, they always underexpand more. And the risk of halt in smaller series, of course, of 20 patients, but it's very clear that the in vivo sizing tends to work better.
Okay. Okay. So in this case, actually, the patient, daughter is very educated. We talked about even when the gradient increased, I wanted to go empirically, NOAC and warfarin, but same issue we were thinking about. Then 1 week later, while we are discussing, she fell and developed intracranial hemorrhage. So we never tried, and of course, then we did a CT, no halt. And therefore, I think I'll have a lot of resistance to do. Maybe we can just give it for 1 month, low dose. Eliquis 2.5 milligram once a day or so. Many of cases, elderly, I know it's always a double dose of Eliquis, but I give many of them just once a day, particularly who is very high risk for bleeding, like this particular case. She's a petite, as you saw that BMI like 18, and of course frequent falls, no intracranial hemorrhage in the past.
Difficult.
Maybe, you know what I will do? Actually, that's a very good point. Knowing that this case, we can't get her back in 4 years if she valve degenerate. We'll do tomorrow head CT. And we see that if that intracranial hemorrhage has remained same or has decreased, then maybe give it at least for 1 to 3 months. Just very low dose of Eliquis.
Yeah.
You measure the level of Eliquis, because this is another useful thing to try.
I think we want to measure anti-10A activity of some sort after the dose of Eliquis to see where we are. Okay, that's a consideration. The lab does it all the time.
I see. Good. All right, I think they're ready. Thank you for this, all the great input. And Gilbert and Kini, they should be ready on other case. I'll join you in a few minutes.
Very well.
Thank you.
Let's go to other lab. That was an involving case, many decisions, including the anticoagulation in the very end, many levels of decisions. Any open for comment before we go to the other lab? Anyone?
Just one question I had was that, what Vinny was asking, that whether we should do an inflation with a true balloon or not. I'm not 100% sure, but this is a good question. That if there are any data to say what, like surgery, we commonly do for the mitral valve 100% of times, aortic many times. If it's not a CE valve, I almost always do it. So
we are using more of true balloon non-compliant, because I think we find that the waste behaves predictably than adding extra CC to the adverse delivery system. And especially after mitral valve involved, we 100% optimize every time on the table. Yeah, absolutely. Yeah.
And a quick question to you, Samir. For cerebral protection in valve, do you think it's a must? I know that there's not too much data, but in a case like that with adherence of the leaflets and calcium, do you highly recommend, or you think that
So yes, I personally think it's a good idea because looking at there are several now new data, not yet published, but suggest that if you have a surgical or a transcatheter valve, the emboli protection is working better for those patients.
for both mitral and aortic, right?
Mostly aortic, the data that I have seen.
Well, good. We're ready to go to the other room, if the other room is ready for us, of course, which I'm not sure the connection is coming out. So anyone, in retrospect, anyone believes that perhaps implanting a 20 millimeter valve the first time could be an option, or implanting an EVOLUT in the first time could be an option? Let's kind of reflect on that. I guess there's no time because I just posed a question, but they're ready in room 1 now. So let's just go there without delay. We may come back to that later.
Okay, same familiar faces with the 2 new. I have on my left side my associate Parasram, he is our structural attending, and on the right side is Rajesh Samdani, or another structural fellow. With that note, let's show you this case number 2, little unusual in the sense 80-year-old patient, progressive dyspnea, and has over the years found to have aortic stenosis, which has progressed to moderate to severe AS now, with also moderate to severe AR. So this is the case with both AS and AR, and therefore doesn't make a full criteria of AS point of view, but we'll show you that echo as well as hemodynamics. And valve was quadricuspid with a normal ejection fraction. So I don't know, maybe we'll ask somebody. We actually have one time unicuspid valve, quadricuspid. I don't know the incidence of quadricuspid.
I have not seen one in my career.
I have seen one unicuspid. So this is the second abnormal, bicuspid, tricuspid, forget it. But we have one unicuspid about 10 years ago. And this is the quadricuspid. The patient has both moderate to severe AI. Catheter coronaries are normal.
Yeah, normal.
Yeah, coronaries are normal. And we'll show, Lucy Safi will show the live echo, if we can show it, and then we'll go to the hemodynamics.
All right, so here's our live echo. In our parasternal view here, you can see mild LV.
The louder, yeah.
We're good. We hear very well.
Hypertrophy.
Okay, good.
And moderate aortic insufficiency on color Doppler. You can see there's very minimal tricuspid regurgitation. And then very lovely here is our quadricuspid valve. You can see that beautiful cross sign. And then the central aortic insufficiency.
Wow.
On freeze frame here, you can see that beautiful cross for the quadricuspid valve. Overall, normal systolic function of the left ventricle, that moderate aortic insufficiency, and now our gradients. You can see that steep incline of your aortic insufficiency Doppler. Your stroke volume here is within the top normal range, and then your mean gradient across that aortic valve for the mixed valve disease is a mean of 24. So, no pericardial effusion to start. That's our echo.
Okay. So clearly, and now with the CT.
Yeah, so CT, you can see small annuli, 20 millimeter on average, and you can see small alveoli, a little bit of calcium at the annulus and LVOT. Next slide. So here's the quadricuspid morphology. You see that on the CT, really beautifully shown that correlate with the echo that Lucy just showed. And this is something that is very uncommon and unusual, obviously. So it's quite remarkable to see that. Next slide. Sinuses are big. You can see that, no issues, not much leak on the calcium, which we saw. Next slide. You can see that here, the root is pretty generous in terms of a left main obstruction risk standpoint. Next slide. You can see that here again, quadricuspid commissures. Access, person, you want to comment?
Sure. Calcified posterior wall, but otherwise there's no calcium on the anterior wall. We used the right side as the main axis. Ultrasound was used for obtaining access.
And looks no trouble.
No trouble, yeah. We did 2 pre-closes, yeah.
So we still, I know Samir said that they use 1 pre-close only, and sometimes put an angioseal, we are still routinely going 2 pre-closes, correct?
We do 2 pre-closes unless the vessel size is small or there's actually a significant amount of calcium, and we tend to use another closure device with another mechanism on the way out, such as an angioseal, if we don't achieve hemostasis.
I said then only. So yes, we do some cases, and I know we are the part of the Mentor trial, which has a very Sahil and Gilbert are the
and George is the PI, but yeah.
And George, yeah. So basically, now this is the case of medical necessity for mixed AS and AR, and wanted to show the hemodynamics. Can we go to the hemo, please? Look at this. Why this case? To me, I think it's the more AI than AS.
Yeah.
Look
Wow.
at it.
Look
This
at
is the
that.
hemodynamic. Look at it.
Pressure is 160 over 35.
30.
Yeah, something like
Yeah.
that. A very, very
And
classic
that is why
picture of
she's
chronic
so
AI. Well, that's why the jet was also relatively smaller than expected. The pressures are equalizing rather quickly, not a lot of velocity there.
Perfect. I'll go back to the fluoro, please, now.
Yeah, we'll show you the aortogram. I mean, the views, implant views, and also the arch angiogram, why we could not use Sentinel.
So this was, I think we did a coronary angiogram today, non-obstructive, almost normal.
Yep.
Cameral fistula, big cameral fistula.
Oh, that's all they have. Okay, here.
That's the free cast view. Yeah. We can actually get a cast overlap here despite being quadricuspid. And you can see the next slide being the arch angio. So very calcified. So we did not want to.
Yeah,
I know, Samir, would you have tried it at Cleveland Clinic?
There's a lot of calcium and tortuosity in the great vessels. I don't know.
Yeah.
Samir, what do you think about the great
They are
vessels?
very big on that.
I agree.
On cerebral protection. Would you try advancing in this anatomy? We needed your personal opinion.
I would,
because
yeah.
Raj is not there. Yeah.
I would. I don't even do an angiogram, but I just look at the CT scan. But I would definitely try in this one. But again, this patient is does not have much of. We are treating mostly AR, mixed valve disease, and not much calcium, so maybe risk benefit is not in favor of putting a sentinel device because the aortic valve is not super calcified.
Although you could argue that the aorta calcification is a
Is
bigger
more
risk,
important.
if not more so, based on the early data on hits.
Right, but the distal calcification, I think, beyond the.
Yeah, the arch is calcific beyond
Where you
the.
see it, it means it's there further too, I'm sure.
So
pressure come down a little for us. Yeah.
Great. There's a very wide pulse pressure and extremely low diastolic blood pressure here, which correlates with a very significant chronic AR. LV. Also, you can see on the dilated side, that's why the LVDP is also under 20, as we saw.
And please keep showing the hemodynamics on one side of the screen.
Yeah, that would be great. Yeah, we don't need to see the axis. Instead of the axis, give us a hemodynamics on the left side, please.
Yeah.
Yeah.
So we're getting the valve now. We're not going to pre-dilate here because you see there's not much calcium mixed picture, but we might post-dilate if the valve looks underexpanded on the fluoro.
So sometimes, because of the vascular impedance, even after you replace the valve, the diastolic pressure may remain low because some of this may be just calcification of the vasculature.
Okay.
So you can see flush at 3 o'clock, hat marker out of the curve. I think everyone pretty much familiar with the FX technology now, since it was launched last summer.
Yeah.
So we put the picture down, the non, and then we're going to go to the cusp overlap view.
No, this was very, very easy, at least appearing very smooth crossing of the arch, of the calcific arch. All right, what is a pigtail? The pigtail very often gets entangled. You have to re-advance it. Re-advance it later.
150.
Inject.
Good. Very good. Okay. Sinai, inject. Push forward. At 100, please. Push forward, push forward, push forward, push forward. Okay? Push forward.
And down.
No, push forward. No, good, it's good. Don't do anything.
You don't want to pull the pigtail?
Yeah, good. Okay,
See
let's
that?
take a look here.
Take a picture with a little
Inject.
push.
You agree?
Looks good.
What's everyone think? I think it looks great.
Very
Gilbert,
I think
Anyone disagree?
any tips and tricks about commissurial alignment to avoid the posting?
We'll talk afterwards. Let us release the valve first, and then we'll pull the wire back, and then Dr. Kini is going to apply a little gentle forward 150, because not much calcium, we don't want it to move.
Yep.
You can already
Okay, so
see
we
how
keep the pressure a little.
pressure's
Yeah, we
improved.
do a slow release.
A little push, yeah.
Very slow release. Yeah, he's pushing. It's very slow. Good, excellent, looks good. Okay, 120.
Wire back.
Yeah, wire back. Looks very good. Advance the wire now.
Sure.
We'll do hemos. Advance the wire out of the curve. 100.
Get the pigtail ready.
Maybe go to less magnification so we can keep the wire down easily.
Good.
Yeah.
Okay. Yeah, back up.
Come down.
Yeah.
Okay, let's do the pigtail.
Okay, so this is let's go to a cuts overlap view to show the audience. Looks very good, actually. Mag in now. Good, actually looks great. So you can see the CTAP is in the inner curve. One dot in the inner, so I think it's good commercial alignment. Pickle.
And tell us that how would you do the commissioner alignment? That's the
Look at that, perfect. Now 2 and 3. Okay, good, well expanded. Okay, let's do the echo now, please. Okay, let's walk this out. Let me hold the sheath. Floral.
Wait.
Yeah, floral.
I'll see, wait.
One second, then we'll exchange with a pigtail.
All right, any comments from the panel regarding
What's
the...
that? Okay, now I'll answer your question, sorry. So you can see the head marker should be facing you with the cuts overlap view. That's always been. It's like Pro Plus, but FX now is easier to do. And if your head marker is on the inner curve of the descending aorta before you go to cross the arch, you need to rotate it to the outer curve to maintain that. So, and the key is try to get the dots, and we'll show that. See, look at right down there. Well, Hafiz show the echo. We can show you some floral images.
Keep going.
Just show it here. Okay, so here, so here you can see the head marker is at the inner curve. I mean, it's facing you. So if the head marker is away, it's on the inner curve. That's not good. And so the dot, you can see one dot is facing the right side of the screen. That's promising, but it's not absolutely necessary. You can see sometimes it's more symmetric. But the key here, and we teach this to everyone, all our fellows, 2 of the 3 dots have to be below the annulus. So you can see that only 1 is a little higher, the 2 are below, so you know you didn't miss the annulus. And you can see here, the FX is much more symmetric. It's about 4 to 5 on the left, and then you can see among 3, the dots are very nice to tell you what the depth is on this view, LAO view, and we pull back the wire and we release slowly, as you saw. And this is the cuts overlap view now. You can see pretty much stay where it is. It didn't go up, it didn't go down, despite not much calcium with this case. So we're very happy with it. How does it look, Lucy and Hafiz?
So far, it looks great.
Speak up, please, Lucy. I couldn't hear you.
So far, it looks great.
Yeah. We have a pigtail across, right?
Yep, there's a pigtail across. There's very minimal posterior. Looks great.
I think we can leave it.
But if you have to post dilate, what size? Tell the audience. What will
I think it will be 21 true, if I'm not mistaken.
Anyone here would post dilate?
I mean, I think it looked a tiny bit constrained still at the annulus angiographically, but you don't have AI, you don't have much of a PVL, so I think you don't need to.
Yeah, there was a little bit of an appearance at the base.
It may still expand a little bit over time.
In the cusp overlap view, the very base was a bit, it was an impression, but I mean, the result is good. Maybe I don't see anyone here who is enthusiastic about post-dilation.
I think you have to wait.
Yeah, and it's also the 2 millimeters already, but small LVOT. And remember, there's annular and LVOT calcium, right? So be careful what you wish for. There might be reason for that small trivial PVL.
Take the echo is done. Out.
Yeah.
Okay, go. Yep. Let's go. We do the hemodynamic. The diastolic pressure, which was 40, 35, 40 is right now 60. But we're going to show that hemodynamics now.
Yeah, that would be great.
Mean gradient on echo 6.
Yeah. Mean gradient is 6 on echo, so that's very good.
Echo 6.
Good.
Yeah.
It's
And
caught
AR
in the
index,
inner.
if we take, let's see,
Just be careful.
from that point of view also.
Yep.
Pigtail has to go down.
The pigtail ones. It's caught in the inner. Yep. Yep. Good. Okay. All right. So let's do some hemo and zero.
Flush.
In the meantime, I'll show the audience at the coplanar view, which is 17:1. So we have to look at the C-tab as well in terms of how inner it is. That's kind of our preference to do a dry CNF 2 views to really check the alignment. With this, we typically never needed to do any whole CT. We can actually go back to the pre-CT to register. You can see the C-tab is the inner curve, around between the 2 to 3 crowns at the inner, so you know that it'll be excellent alignment. Now this is a quadricuspid, but obviously it's hard to align with 3 to 4, but at least, we can see it well enough to should be, the left main should be okay. So here's the final result. You can see
no systolic, diastolic has gone up, but still low.
Yeah.
And maybe still there is a little bit of leak, parallel or central, maybe because of the pigtail. We'll pull it out and take another aortogram.
Well, the
Because,
valve
I think compliance. Yeah.
Yeah, it could be just compliance too, right?
This is what I was expecting because in the initial aortogram didn't show that much AR, so.
Yeah. Good. Let's do the aortogram.
Let's do high quality aortogram. You want this view of the other view? Just in this view, the spine overlap, we don't see very well.
No, this is the different view already. Use different view. You saw it was cusp overlap. This is one more coplanar view.
Yeah, just show a little bit more. Yeah, show the LV a little bit more. That's what I meant. Yeah, good.
Okay, ready?
Yes. Focused on the.
Yeah. Okay, everyone good?
Okay, ready.
Go.
It's there.
Just a little bit there.
Should we post dilate?
I would post dilate, because you have good
We can
conduction,
post.
you have good conduction, good height.
21 or 22?
No, let me know.
Now. Pigtail.
21 true.
21 true, okay.
Go slow because the LVOT is smaller with the annular calcium, the LVOT calcium. So
Interesting.
I would do it in the cusp overlap view again.
I think by echo, the AR was a bit underwhelming. I think somehow this was a little bit of a surprise.
I
mean, we did not pre, there was annular calcium, right? So you just recross.
I think you have room to post dilate.
Get the J wire also ready.
Yeah, it's it's on it's 2 millimeters already on the cusp overlap view. You saw, right, Howie? So we have to be very careful, make sure the systolic pressure is low. Because remember, this is a mechanism AS-AR. We fixed the AR, okay? So, and the AS obviously has also been fixed. Now, there's some residual PVL. I mean, definitely it's better than baseline. So clinically, the patient should not feel a difference with this kind of AR. But if you want a perfection, you can do that. But you have to be mindful of the risk of, root injury, right? Remember, there was a bit of a calcium at the annulus and LVOT. And LVOT is smaller, so I would go slow on the inflation of the balloon.
But calcium is not that,
It's not prohibitive, but it's there. Yeah. So it's just something to keep in mind, right? Yeah. Especially for, not for the faculty panelists here who do a lot of cases, but for those who might just be starting our program that, we always say, you don't want to have a root rupture, which is a very emotionally rich experience. Definitely people will know that they have a scar versus people will probably not know much of your mild PVL. So.
You don't have to oversize very much either. You can get away with a 20.
No, we're not. This is the mean diameter of the annulus is 21. Yeah. So 20. You could argue we could go even 20, but I'm not sure 20 will touch it. Yeah. LVOT is around 19 point something.
I think it does. And sometimes it just needs to push open the cage a little bit. It doesn't have to actually.
No, I agree with you. The waist is well expanded, as you saw. It's just more the inflow part of it.
Yeah, 100% is the very last few struts. It's just a little bit pointing inward, slightly inward. Than anything else, was just his appearance.
180.
Okay, we're going to post dilate now.
Okay, slowly we are going up.
No.
Make sure go a little bit more in.
Okay, go.
Good.
Go. Mm-hmm. This one you can go fast.
Okay,
slow.
That's it.
Full.
Yeah, full.
It definitely expanded more down there. It definitely did.
Looks better. Good. Get the pigtail again.
Okay, off the pacemaker. Yeah, very good.
No.
Stop the pacemaker. Yeah, good.
Okay, so what we are going to do, knowing that the diastolic pressure and we just do the aortogram, I don't think we need to do it, let's do the picture, yeah.
Just veniogram.
Yeah.
Let me just take this.
Yeah, the audience is very eager to go for break. We have 1 minute.
Yeah, we are on time.
Yeah,
On time.
This is a first. This is a first, Dr. Sharma. We're on time, and in going to the break. Usually we eat half of the break.
Gilbert prepared everybody. Guys, girls, don't be over. Every on time. So I say, okay.
Dr. Sharma, in terms of...
Much better.
Yeah,
Much better. Go on.
in terms of valve selection...
Okay, go ahead, Hafiz.
If you had Gina valve available in your shelf today, would you choose for this case?
Yeah.
That's a great question, but Jenna has free commercial, wings, and this is a quadricuspid valve. So I don't know how you would orient it, but also right now, as you know, the trial was only for pure AR patients. This one, if you look at the CT and look at the echo, there is some fibrotic component, which you saw the gradient today was valve area less than 1, was 0.8, 0.9, and mean gradient of 23. So I'm not sure if this patient would have qualified for that trial, but certainly commercially, if you have a tri-leaflet valve, this could be a potential option. And in fact, in Europe, they are doing some of that in steno AS patients as well.
Combined.
So,
all right, with that note, we exactly finish at our 10:45 and go for a break, and then we reconvene at 11.
No, very well, very well. Thanks the entire panel. We're going to have a nice break, and we reconvene here. Moderator, Danita, Askar, and faculty for mitral valve intervention sessions. Have a nice break.
Right, right, right time.